Welcome back to 50 Studies Every Neonatologist Should Know. I'm Dr. Adnan Hadid. Study number 26, the iMPACT RSV trial, published in Pediatrics in 1998. This is the trial that gave us Palivizumab and started an argument about who should receive it that we are still having today. Be careful with the wording, because the wording does a lot of work. Safe and effective for preventing serious RSV illness, respiratory syncytial virus, in premature children and those with bronchopulmonary dysplasia, BPD. Not a claim about death, not a claim about intensive care, and not, at this stage, a claim about whether the price is worth paying. Every controversy that followed lives in that gap. The question, cleanly stated. In high-risk infants, either under 35 weeks gestation and under 6 months old, or under 24 months with BPD still on treatment, does monthly intramuscular palivizumab, compared with placebo, reduce RSV hospitalization over 150 days? Note that the primary endpoint is an admission, not a death and not an ICU stay. Hold on to that. Before 1998, you could offer RSV prophylaxis, but it meant RSV immune globulin, given intravenously over several hours, repeated monthly through the season. For a fragile ex-preterm infant, that is a genuine undertaking. Venous access, transport, clinic time, parental burden. A humanized monoclonal antibody offered the prospect of the same protection from one intramuscular shot. That logistical shift is arguably as important as the efficacy result itself. 1,502 infants across 139 centers in 3 countries enrolled in the 1996 season and published in 1998. Randomization was 2-to-1 in favor of Palivizumab, a common design when a sponsor wants safety exposure as well as efficacy. It was masked, placebo-controlled, and followed infants for 150 days, which is 30 days past the final scheduled injection. 2 entry routes: prematurity at 35 weeks or less with age under 6 months, or BPD under 24 months still needing treatment. Significant congenital heart disease was excluded, as was immunodeficiency and recent RSV immune globulin. But notice the breadth of that first door. A 24-weeker with chronic lung disease and a 35-weeker who went home on day 3 are not the same patient, and they carry wildly different baseline risk of admission. The treatment arm received 15 milligrams per kilogram of palivizumab intramuscularly every 30 days, 5 doses, covering 1 RSV season. Controls got an identical appearing placebo at the same volume and on the same schedule, so families and clinicians experienced 5 injections either way, and masking held. 2-to-1 allocation means roughly 1,000 infants received drug and about 500 received placebo. The primary outcome was RSV hospitalization, a positive RSV antigen test during an admission with evidence of lower respiratory tract illness. Secondary outcomes covered severity, length of stay, oxygen days, ventilation, intensive care time. This is a sensible endpoint set, but it's worth naming what an admission is. It's a proxy for severe disease, and it's also a decision made by a clinician, which is why masking mattered so much here. RSV hospitalization fell from 10.6% to 4.8%, a 55% relative reduction. Confidence interval 0.38 to 0.72, p less than 0.001. Total hospital days and oxygen days both dropped. Intensive care admissions were 1.3% versus 3%, statistically significant but built on very few events. Safety looked clean, 11% versus 10% adverse events, and almost nobody stopped. Now hold the absolute difference in your head, 5.8 percentage points. This is the slide worth pausing on. 10.6% of placebo infants were admitted, 4.8% of treated infants were. That's the 55% everyone quotes. But the bars also show the absolute gap, 5.8 percentage points, which works out to a number needed to treat of about 17 across a whole season, and the confidence interval on that reaches 36. Both readings are honest. Which one you emphasize tends to depend on whether you're writing the label or writing the budget. Methodologically, this is a good trial. Masked, placebo-controlled, with an objective endpoint. The caveats sit elsewhere. The lead statistician was employed by the sponsor. The subgroup estimates for BPD and preterm infants are unstable and shouldn't be quoted as separate effect sizes. There was no prospective cost analysis, and the number needed to treat climbs steeply in some groups. And enrolling everyone from 24 to 35 weeks under one door serves a broad label, better than it serves the clinician deciding who to treat. Watch what happens next. A companion trial in congenital heart disease found a 45% reduction. Guidelines then spent years narrowing eligibility as cost-effectiveness data came in, the 2014 AAP update being the clearest example. The 2021 Cochrane review of 5 trials and over 3,000 infants confirmed the effect, relative risk 0.44, high certainty. Then nirsevimab arrived. 1 dose per season, and much of the targeting debate dissolved. Maternal vaccination is now moving the field further still. So, Study 26 in summary. Impact RSV showed that passive immunization works. Monthly Palivizumab halved RSV hospitalization in high-risk infants. It was safe, and it replaced a monthly infusion with a monthly injection. What it did not show was a mortality benefit, and the intensive care difference rested on a handful of events. The question it left open, who is high risk enough to justify 5 doses, has driven guideline variation ever since, and is only now being settled by single-dose products. Roger Soul's commentary sharpens the point. Even among these high-risk infants, only about 1 in 10 controls was admitted, and pediatric intensive care, the outcome that genuinely frightens us, occurred in around 3% and wasn't meaningfully changed. That's why the conversation moved so quickly from efficacy to value. His second point is the bitter irony of the post-COVID years. Serious RSV came back in otherwise healthy children, and the answer may turn out to be maternal vaccination and universal infant immunization, rather than targeted monthly injections. Full citations are on screen, led by the 1998 Impact RSV paper in pediatrics. That's Study 26. I'm Dr. Adnan Hadid. Thanks for watching, and I'll see you in the next one.